So hi everyone, welcome again to JOSPT Asks, the weekly chat where you, the audience, get your questions answered. My name's Clare Ardern, I'm the Editor-in-Chief of JOSPT, and it's really great to be chatting with you once again, whether you're joining us live or whether you're catching up later on with the recording. Thank you so much for taking the time to join us. Please, if you'd like to suggest a guest or a topic, do so on our social media platforms. We're at JOSPT on Twitter or JOSPT Official on Facebook. Today on JOSPT Asks, it's a real pleasure to welcome Dr. Kieran O'Sullivan from University of Limerick. Kieran's Twitter bio describes him as a physiotherapist, a clinician, a lecturer, and a researcher. So he's got a really great, well-rounded expertise to be joining us today on JOSPT Asks. And I'm sure that many of you will be familiar with Kieran's terrific research in managing back pain. Kieran's a specialist member of the prestigious Irish Society of Chartered Physiotherapists, and today he's going to be answering your questions on helping people with back pain get back to activity. So welcome to JOSPT Asks, Kieran.
Thanks very much, Claire. It's lovely to join you and happy to be here.
Oh, it's great to have you here. So thank you for making the time. I thought we might start by asking you to share your philosophy on managing or your philosophy to managing low back pain. What guides your clinical reasoning and your decision making, Kieran?
Okay, so the short answer nowadays, I suppose, would be that we'd like to say we're doing all the right things by going on evidence-based practice, looking at what the guidelines say and so on. But my own personal kind of journey in terms of understanding back pain starts, like a lot of it, is with my own personal experience. So like a lot of us, when I was younger, I played sport and I developed a few aches and pains and a few injuries along the way. And some of them were the typical soft tissue injuries, like I had a recurrent shoulder dislocation and so on. But then in my early 20s, I developed persistent kind of recurrent back pain, which had a big impact on my ability to play sport. And at that time, playing sport was a key part of my identity, and it was something I really enjoyed. And then I saw some very good people and tried to do a lot of sensible things. But essentially, the mindset or the way in which my back pain was viewed by myself and lots of other people was that I had damaged my back. I had a scary thing in my back called a disc bulge, which was pressing on one of the nerves in my back. And so I didn't really see, I suppose, all the various reasons I got back pain. And I would, if you asked me back then what was going on with my back, I would have said, for no apparent reason, I got an injury and it wasn't responding normally. Whereas now I view that whole experience very differently. And to be honest with you, I had a lot of treatment. And again, some of it helped me, don't get me wrong. But it was only when I really started to understand all the things that contribute to back pain as they applied in my life that I started to see a lot of these patterns in my patients. And then when I started reading more broadly, I saw, well, actually, this isn't new. Lots of people have been talking about this stuff for a while. This idea that, well, what happens in your bones and your discs and all these things are relevant, but they are one piece of the puzzle. And so my philosophy on back pain is that sometimes it's quite simple, like knee pain or ankle pain. You can hurt tissue and you can sprain an ankle and sprain your back and so on. And sometimes, in fact, quite a lot of the time when it's been there for a while, it involves other parts of your health. Now, often the go-to area in that is psychological factors and mood, anxiety, stresses, but a lot of the time it's just the run-of-the-mill stuff in everyday life. Fatigue, work-life balance, commuting, not enough time to exercise and eat well, and so on.
So we're talking really about the biopsychosocial model here, aren't we?
Yes, and so and we'll say, look, that model isn't new and it's been applied to back pain for many years. And I guess I would say that even now we still just pay a kind of a token effort to that, or we only consider the biopsychosocial model when everything else has failed. And that applies almost to the way we're trained, but also in terms of the way healthcare is often funded. That will say more comprehensive or multidisciplinary care is generally saved once everything else has failed. And we'll say it's a real challenge in terms of managing back pain, because if we contrast it with, say, something like cardiovascular disease, like cardiovascular disease remains a major problem in health, but there is, at least amongst, Joe Public on the street, an understanding that factors like cigarettes are important and diabetes is important, but also things like stress and physical activity levels are important. So there's an understanding that a range of different factors can kind of accumulate and increase your risk. Whereas the same people on the main street, they're considering back pain, overwhelmingly it's still focused on physical factors like the way you sit, the way you bend, and pathoanatomical factors such as the shape of your spine or your disc bulges. And again, of course, they are part of the picture. But we spend an awful lot of time in the clinic trying to get those basic building blocks of understanding that this other stuff in your life is important as well.
So then I guess, how far does, if we're both physiotherapists, or physical therapists, how far does the scope of practice of the physiotherapist extend in the biopsychosocial model? What's a reasonable or a safe or an ethical way or area to go into? Are we broaching things like sleep? Should we be broaching things like mood or stress or weight or diet? Or are we completely out of our lane and we should stick to those very biological, physiological things?
Yeah, it's a really important question, and it's a concern that often comes up. I've faced criticism in two different ways that are almost directly contradictory, which I've discussed before. In the one sense, people will often say what we do is just good physio. It's just, applying sensible practice where you focus on exercise, educate people, and try and get them healthy. And I'm actually open to that comment that, like, don't overcomplicate it. This is just good physio. Another criticism is, however, that this is so weird and different that it's almost dangerous, in that physios should not be asking about things if we cannot fix them or treat them. So we shouldn't really be delving into too much personal information about a person's life, financial situation, relationship status, mental health, and so on. Now, there's probably some merit in both of those arguments, but they are very different arguments. So I remember one point, Peter O'Sullivan from, I was going to say from Australia, very important to say from New Zealand, but living in Australia. I remember at one point he was giving a workshop in Limerick, and he had, as usual, given a great demonstration of how to get people to tell you stuff that's important in their life. And someone made the point that, they weren't, as a physio, very comfortable asking some of those questions or discussing some of these things. And his response pretty provocatively was, well, I wonder how your family feel about that. In terms of the stuff that we're talking about here is actually important in dealing with our husbands, wives, brothers and sisters, and friends and work colleagues, being able to communicate honestly with people about the stuff that's important to us. There still remains an issue then of, well, how far do we go and what can we do with it? So one of the parallels I often make is that I'm not a psychologist, nor do I want to be, and equally I'm not a dietitian or a nutritionist. But we're quite comfortable with the idea, if you've got somebody with knee osteoarthritis and morbid obesity, that at some point them gaining control of their weight might be worth looking at. And so there's almost three levels of what you would do. And I would say, first of all, it's probably reasonable to say, would we identify a link that, reduction in their body mass might help their knee pain? And most people would say that's reasonable. And I would say you could say the same, but at the very least, could you make people aware that there's an evidence base out there that your mood and stress levels are associated with pain? So, they are connected. And then I suppose the next level, the second level, would be that idea that asking them, would you be interested in trying to find out how you could help that? And that might be something as simple as pointing them in terms of weight loss to the nearest weight management program. Or here's a leaflet on, look, that's the latest healthy eating advice. Or equally in terms of mental health, what are some sensible things that most people can do for mild to moderate depression? And it looks like from all the systematic reviews that getting people active and doing stuff they like is really, really effective in terms of, mild to moderate depression. And I think all that stuff is very much in the scope of practice of physiotherapists. There is then a final third layer of kind of complexity where we probably need more help. So if you've got somebody with significant morbid obesity who really is struggling to stick to any kind of structured dietary program on their own, they probably need a referral to specialist attention and care. And that's probably the case for a small subset of people with significant mental health disorders, and especially, of course, if it's poorly controlled, suicidal ideation, self-harming, or harming others. I would say that's a really small proportion of the patients we see, and even if you talk to some of the expert clinical psychologists who research pain, they would say that's a small proportion of the overall population of people with pain. They are there, we need to take care of them. But an awful lot of the time, it's the run-of-the-mill stuff that gets on top of people. So for all the concerns that a lot of physios, and again, I share some of them, but for all the concerns we have about the stuff that we throw under the psychological bucket, I think we have a much bigger challenge in the social angle in terms of So we are getting a bit better at understanding some of the factors around depression, fear, anxiety, and so on. But trying to tease out and then try to modify some of the factors that are related to your family life, your relationship status, relationships with your kids, close people in your personal life, your work status, how much you like your job. These are really, really tricky things to ask people about, to have an honest conversation about, and then you are really left with a decision as to what I'm going to do with that. And I guess even this afternoon I had a session with students, and a follow-up email was around like, what do we do with that information? And I think it goes back to the idea that sometimes we think, I will only ask a question if I have the answer to it. But sometimes asking the question is useful just to get a better understanding of where the person's at. And if we're honest, a lot of the time we don't have the answers. But if you skip forward and ask people like, what did they like about seeing a consultant or a physio? One of the really important things is if the patient says, he or she listened to me, took the time, and was interested in me. And some of the stuff around, it's not to be prurient or nosy, I hope, but actually spending a bit of time and getting to know exactly what's going on in your life shows at least I'm paying you a bit of attention. And it's amazing how many people will still say, I've never told anybody all that stuff. And sometimes there's almost a sense of shame in that. And the stuff they're often reporting as almost embarrassing for them, it's the stuff that most of us have in our lives at some point in time.
So you mentioned that Pete in his workshop asked the question about about feeling comfortable asking these questions. How do we start to feel comfortable? I'm thinking back to when I was first out of physio school, and I was so worried about, doing the assessment correctly and getting the right exercises, thinking about and also feeling that I was young and I didn't have sufficient life experience. How do we start to get comfortable asking some of these questions that perhaps might feel uncomfortable to us, may or may not feel uncomfortable to the person in front of us?
Yeah, I wish I had a good answer for this. I think like a lot of it comes down to exposure being a key way to learn in any form of life, whether you're exposing yourself to training loads or exposing yourself to kind of the speaking in public. And so for here, I think a lot of it comes down to practicing communication and being comfortable with it. Now, I've got this wrong, and I've seen other therapists get this wrong with the best of intentions in terms of forcing questions or asking a question and not being ready for the response. Like, I really don't think we should be asking somebody, and it doesn't come up that much, let's be honest, but I don't think we should be asking people if they're thinking of harming others or harming themselves if we cannot handle the answer at all, and if we think it would upset us or harm ourselves in other ways. But again, the most common stuff we ask people is like, how is your life? How is your work? How is your family? How are you set up financially? These are slightly sensitive and personal questions. And if we want an honest question, an honest answer, we should feel comfortable with, I suppose, we should make the person feel that this is a safe, trusted environment and help them understand why I'm asking that question. So, for example, when I've handled these things wrong before, it's been by rushing and using the wrong questions. And sometimes it's the smallest thing. So, for example, if I think of situations where I've handled it badly, generally time is the thing I blame. That I'm feeling rushed and this person is taking too long, and I think I know where I want them to go, so I'll push it. But sometimes it's the smallest thing. I remember seeing a man in Ireland, a patient, and there would have been a few like him, maybe in the height of the financial crisis 10, 12 years ago. And he was talking about the stuff that was going on in his life, particularly around losing his job. He worked in construction and was, financially in under big pressure, had overcommitted, and now was a manual worker with no sign of getting any good job with anything like the same income coming up. So I spoke to him and paraphrased this, and I spoke to him about the stress that he was under. And he really didn't like me calling it stress. And it really backfired, and I'd like to pretend I managed to turn it around, but basically I lost him in that few seconds because he spoke quite angrily about how he knows lots of people who are stressed, but stressed was in his view kind of for weak people who really were no good in their life before, and he hadn't used the word, but the way I was probably rushing things along, I messed it up. And I've had multiple experiences and situations like that. And I think one of the things we keep reflecting on is the idea of using the words the person is using themselves. Because if they've brought it up, so for example, if the person's brought up, look, I'm worried about stuff, well, then it's okay to say, what are you worried about? you know, whereas if they say, I'm worried about stuff, you don't say, well, what are you overreacting to now? You know, there's a whole other series of ways in which we can stigmatize people and so
Now, you mentioned the issue of time, and
on.
lots of us are working in very different contexts, different health services that are set up in different ways. And that puts different pressures and different restrictions on what we can and can't achieve in a consultation. What do you see as priorities, or what would you suggest to people who are trying to figure out, should I prioritize the talking part? Should I prioritize the self-management part? Should I prioritize the figuring out the referral or the exercise part?
Yeah. So I think I've got to acknowledge, first of all, like my caseload's probably a little bit biased, so I'll come back to that in a second. But I think the biggest thing we can do at the start is set clear expectations about what I'm offering and what the person is looking for. So if I look at my own caseload, when I've been seeing patients, particularly in Ireland, I'm typically seeing people who've had pain for quite a long period of time. It would vary, but like it would be typical they'll have had pain, this particular pain, for a couple of years, and they've probably seen a lot of different people. And a lot of the time that's portrayed very negatively. People say, oh, that's people with persistent pain. That must be, you know, hard, and sure, they'll never get better and so on. I would say one of the great positives about that is it's almost easier to say, well, there's no need to try X, Y, and Z because you've tried it all before. So I won't label any treatment in case it's seen as being critical. It's not that treatment. But let's say I'll say, well, you've tried treatment A, and you know, Claire did that with you, and she's at least as good as that as I am. So if it didn't help with her, there's not much me point kind of trying that again. And setting out, so in my case, it's sometimes easier to say, well, you've tried A, B, and C and D. It's worth maybe looking at this again and trying something different. So I think that helps. In contrast, I've found it more challenging sometimes where you'll have sometimes a patient where they're in the early stages of neck pain or back pain, and without being negative, you can already see their trajectory is not looking very good. So maybe there's a lot of pain, coping very poorly, sleeping very badly, uh, possibly some anger around an injury or an incident in a car accident or work, and you know, other stuff going on where life is looking pretty poor. But they've only had this for maybe 2, 3, 4 months, so it's very hard to visualize that this is not just tissue healing that's taking a long time. They also might be waiting for an MRI scan, and that might offer the solution. And in those kind of situations, I've got to be honest and say it's really tricky to kind of handle that situation because, you know, they haven't had pain for 6 months. They wouldn't even meet in many cases the definition of persistent pain, but their trajectory is challenging. So I think they're probably some of the more tricky cases. So in terms of going back to your question, in terms of prioritizing what we do, I think in those situations we have to know what they're looking for and make clear, well, what I'm probably best at. And that sometimes, you know, I wouldn't say then that means everything is going to work out swimmingly. And again, that'll vary a lot. So I've had the opportunity to teach in lots of different countries, and I've been amazed at how much the structure varies. So for example, typically with my patients, I will have had an hour and a half for a new patient, but that is a tremendous luxury, okay? Not everybody's going to do that, and it's totally unrealistic to expect that's going to be the standard everywhere. In contrast, a lot of places it'll be maybe 30 to 45 minutes for a new patient. I would still say in that amount of time, you can prioritize and get some useful information from a person. It does, however, reach a point where it's not sustainable. So I've taught in one particular country, like France, for example, with some great physios there, but the standard appointment time is 15 minutes. Now you could have a lot of 15-minute appointments, but that's really, really challenging if you want to try and, you know, get to the bottom of the person's story. And then equally, if you look at the complications of what's billable, it's something that's come up in recent conversations around tele-rehab and COVID-19 and all that. But there are some countries where you will get paid better or you can bill more effectively if you offer certain treatments rather than others. So we got to be pragmatic in terms of trying to say, maybe I would like you, Claire, to do, you know, treatment A instead of treatment B. But if that means you won't be able to pay your mortgage at the end of the month, I don't think I should, you know, consider you a bad person for considering the one that will pay the mortgage as well. So that's a very long-winded answer to you. But in terms of so I think time is critical. I'm lucky in the situations I've been in, and not everybody's going to have that amount of time. But even if it's down to 30 or 45 minutes, I think we got to set out some real clear expectations of, well, this is what we're going to offer. And most of the time people will either kind of be happy with that or say, look, I might be better off going somewhere else.
Yeah, I really like that suggestion of it's about setting up expectations, really, isn't it? It's like, this is, let's establish what are you expecting, and let's establish what I might be expecting, or at least what I can do, and then can we meet each other somewhere, or is this just not going to work out, and then we move on.
Yeah.
Now,
And again, look, appreciating that that's going to be more tricky in some situations if you're in the private sector versus public and so on.
Now, you touched on imaging. We're going to come back to imaging in a few minutes, but I do want to pick up on this concept. We're almost talking about back pain as if it's an inevitable part of life. We're not really talking about prevention. And in a lot of musculoskeletal conditions, and certainly from my background in sports, there's a huge focus on preventing injuries, or at least reducing the likelihood of an injury occurring. Why haven't we been talking about prevention? Is back pain something that's just a given, it's going to happen to us all, and are we better off figuring out how to manage it well, and accepting that it's part of life?
So the short answer, I'm not good at short answers, as you'll have twigged already. The short answer is, I think we shouldn't probably be trying to prevent all back pain. To contextualize that, and you'll know this data better than me, so I better be careful. But if we look at the sports injury data, I think what it would tell us is like hamstrings and so ACL especially, not that frequent, big impact. Back pain, loads of it, but like most of the time in athletes, a niggle, they're not missing many games from it. In fact, if we look at the back pain absenteeism stuff, it's usually after imaging. So they've a grumble with their back, but then they get imaging, and now we've decided they must miss something. And if we look at, we'll say, the prevention stuff, if you look at it from a general health perspective, there's a big difference between preventing fatal or highly morbid or conditions with a lot of mortality, and preventing stuff that's pretty benign. So, for example, if you're trying to prevent a type of breast cancer that's affecting women in their 30s and 40s, who would ever argue against that? As against that, if you're talking about preventing, if we take, for example, men in their late 80s developing prostate cancer at any point, it's a very different question. Again, it's not saying we want them to get prostate cancer at that age, but it's a very different likelihood of them ever developing it. So my argument with back pain, and actually I shouldn't say that, lots of other people, and I agree with them, lots of other people have agreed or proposed that back pain, in Norton Hadler's words, is a predicament of life. That it is like some of these other things that aren't very pleasant, like constipation, diarrhea, tiredness, headaches, that even
Taxes.
taxes, feeling sad, feeling fed up. That is horrible, and it's no fun, but it is completely abnormal to expect that you wouldn't go through life with one of these. So, for example, being tired for a day is no big deal. Being tired for 6 months is a very different thing, and it is probably reflective of a significant health condition. Being sad for a day or a week if something bad happens is again probably an adaptive process. Not much fun. We'd like it to end, but again, probably normal. And I'd say the same about back pain. That if we look at all the data, all the stats tell us almost everybody gets it. Now, if you could tell me there's this little vitamin you can take, or it's like fluoride in the water, and you take that and all goes fine. The question becomes, how much time and money would I spend trying to prevent it? Because at the moment, there's a whole industry around these things. So, for example, if we look at when you start a new job, the likelihood of you being, advised on the way to sit, the way to bend, the way to stand, and all that, there's a lot of money being spent on this. It's not as if we're not doing anything. And all the evidence would tell us, first of all, that probably doesn't work. And there is at least a suggestion that some of that message around ergonomics and posture is kind of undermining the sense of the body being robust and strong and resilient. So I have to be honest in saying we don't have enough data to say that, prevention is a bad thing. All I'm saying is there's a lot of time and effort being spent on it. And same as we would say, look, we're spending a lot of money on stem cells for knee osteoarthritis. Is there evidence for it? You wouldn't say, well, there's no evidence it does any harm. The onus is on the people who are providing this intervention, saying, well, does it help? And if you're not providing that evidence, I'm not sure how much I should be funding it. And there's an entire industry and loads of business being generated on the back of, we can prevent back pain. First of all, the data tells us that we're not successful. And I really think it's a different thing to, I suppose there's a different argument that we really shouldn't be preventing it in terms of everyday back pain. How we handle the prevention of secondary disability is different. So for example, I would consider it to be quite different if somebody said, look, I've got back pain and it's affecting my ability to work, and I've had it for a week or 2 or 3 or some period of time, and I'm not sleeping, I can't function. Then we're into treatment and preventing that becoming an ongoing problem.
So let's talk imaging. When, because I promised we'd come back to it, when and how does imaging come into the back to activity picture?
Okay, so a couple of important things to acknowledge. First of all, again, I'm a physio. I can't order imaging. I'm actually not really that good or interested in looking at images. You know, a lot of physios will be much better than me at even understanding what's on an image. So I don't claim any particular expertise. I think imaging is wonderful when used appropriately. And we've got lots of examples of people having important diagnosis detected from a specific, fracture that's missed type thing to underlying serious conditions. The problem is it has become, the hammer to hit every screw. And so we've ended up with a situation where the signal to noise ratio is all wrong. We're having people with anything and everything being detected. Where it is very useful, I would say my perception of where it's useful is much narrower than others. So I would be pushing imaging straight away if there was a suggestion of a serious pathology affecting, cardiac minor syndrome or anything like that, or if we were worried about, infectious or invasive conditions, we would be sending for imaging or bloods and all those kind of things. So any of the red flag things. Again, if you look at, I think the patients and the population you see would determine this. So if I was working in an acute triage center, I'd almost certainly be ordering more tests than if I'm seeing patients who've had pain for 3 years, which is getting a bit better, getting a bit worse. But if it's just bouncing around the place, that's not an invasive, melanoma. When it comes in, so my feeling is a lot of people will say, well, it's useful because it might be the reassurogram, that they'll have the image and it'll reassure them. I'm yet to find one of these people, one of these people who says I had the scan and I feel much better after it. I'm sure in the right hands it could be. But my sense is if it isn't specifically around ruling out a serious pathology or a very specific condition that you're worried about, I fail to see it starting to add much benefit. Even, for example, a lot of the guidelines in fairness would start saying, oh, if they haven't started recovering after, some of them say after 6 weeks. From my view, that's way too soon. The median recovery for an episode of back pain is 6 weeks. So at that, you would be you would be imaging 50% of people who end up with low back pain, and that's not in any way justifiable. So a lot of people would say, well, I'll use this and then reassure the person, and then they'll, become more active. I generally am seeing that. I appreciate totally that there are people who will go for a scan because it's what they want. It might also be a requirement that if I want to go and see the physio, I might have to get it. And in those cases, I think all we can do is almost inoculate them against the bad news before they go for it. So start asking them, well, what do you think will be on it? And what are you hoping for? And getting them to think about, well, what are the chances that you, at your age, would have a scan that will say everything looks pristine?
That was exactly what I was going to ask you. So thank you, because I think there's a couple of different scenarios here, because it could be that the patient comes into you with the expectation that I need to have a scan, and then the conversation is about, well, how important is this? Another scenario is, as you described, the red flag scenario, where you as the clinician are trying to decide whether you think it's appropriate. And then it could be a third situation where the patient comes into you having already had the scan and wants you to explain what the pictures show, or perhaps might even say, look, this is explaining everything and it's all a disaster. I've got my back looks like I'm 80 and I'm only 20. How do you deal with that? How do you talk with patients about what you see on the imaging pictures?
Yeah, so first of all, I'm very wary about even looking at the images and adding my 2 cents to it. Again, I'm happy there are other physios who will be better qualified and safe and competent with that. I just haven't spent enough time, or I'm not really on top of it. So there is nowadays, a real pressure, from patients who want another opinion. So they'll bring the CD or they'll bring the scans and all that kind of stuff. but I think there are enough people who are better qualified than me to look at the scan. So I'll almost always bring it back to, well, so have you got a copy of the report? Because I can read the report, that's no problem. And I can, more importantly, ask them what they think it shows. And particularly the words that are used. Now, again, if you look at, everybody's different, but if you look at the average report, there'll be let's say there's 20 findings on it. 17 of them will say fine, 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 fine. There'll be 3 of them that say something, and then the conclusion will focus on the 3 that said something. And so a lot of discussion will be, so asking them what they think is on the scan, and I'll acknowledge that there's some other stuff, but I'll also highlight, well, this is good. Do you know why they're saying that? Like, what does caudate quine mean? I have no idea. That means your spinal cord is safe. There's nothing hitting that. And I suppose break down some of the positive news. Again, acknowledging there is some stuff there. The challenge being, we want to know what they heard from their consultant or physio or GP about it, and how catastrophic or otherwise that news was. We have to be careful. I've got this wrong as well sometimes, where I'm not trying to be dismissive, but I ended up dismissing the findings on the scan. Whereas what I was trying to do was decatastrophize them and de-threaten them. So a little bit of it is, again, go back to that thing about expectations. Acknowledge they have the pain. We're assuming we're dealing here with somebody that has nothing too frightening on their scan, but acknowledging there's something in your back that could be sore, or could be associated with soreness, and then bringing them back to, so when did the doctor say that developed? Because if it's like, say, the typical person in their 40s with disc degeneration, your back pain started 3 months ago. Do you think that started 3 months ago? No, it probably didn't. They're generally aware of that. So why didn't you have pain 4 months ago? And again, rather than telling them, letting them figure out. And generally, if you've done a good history, you'll start, not always, but you'll start to spot some patterns. Well, 6 months ago, my job changed. It meant I wasn't able to go for a run in the evening, or, we had a new baby in the house, or other things happened. And start to get them to think about, okay, so if there's this disc degeneration in your back, that means it's gone a bit dry and a bit stiff, etc. But what we know is that if people are in a situation where they can be healthy, move their back, get some freedom from flexibility, get strong, get fit, sleep well, blah, 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 that isn't always painful. And, that's at least a starting point. But I suppose I'm being a bit generic with the blah, blah, blahs, but a little bit of it is kind of saying, what's your story right now? And what words have you drip fed into the conversation before around the change in work or lifestyle or the weight gain? I'm trying to see, because we always want to try and rationalize everything. If you wake up with a rash on your finger, we will kind of wonder about it and say, well, there must be a reason. And I'll come up with some weird and wonderful, well, actually, I got a new soap and, I've only used it once, but we'll try and make sense of everything. And if I'm a patient with back pain and the only explanation I have for my pain is an MRI scan, well, that must explain it. Whereas if there's an alternative story that makes sense to me, then I'll probably a lot of time be open to that.
So it's a bit like what we were talking about at the top, that listening, really careful listening and picking up on some of the language that patients are using and cluing yourself into some of that. And also, I guess, knowing the typical things that we see on MR or on X-ray, that if we image one shoulder, that probably we see something very similar in the other shoulder, similar in the knee and the ankle. And if we image, 100 people out, if we took 100 people off the street, or maybe not in Corona times, but once we're all allowed out of our homes, if we took 100 people, we probably find some degeneration in their spines also, and they don't have pain.
Yeah, and a part of it again is one of the real challenges for some young students, for example, who are newly qualified, is they probably don't have the clinical mileage to recognize the scary stuff. So, if you've seen, let's say, if we change it from back pain, and you're looking at female distance runners. I was examining a PhD vibe on female distance runners this week, and it was super. But if you're somebody who works with that population, after you've been in that area 5-6 times, you start to know the smell of a stress fracture. There's a couple of different things. And so you're probably happy enough that when I should pull the imaging trigger, or no, this just sounds like something that's more minor. And so as a young student, that's a real challenge, because you've got to develop it's not enough technical expertise, it's not enough, but you can develop more confidence that, well, I know what I'm looking for when I'm looking for caudate quine syndrome, or, when to be worried about somebody developing a drop foot. And so that's a challenge in the early days. But then, as against that, what I do see with some newly qualified physios is that they have less of the baggage that people like me, the middle-aged people like me, have, where they've actually grown up or graduated to college with a more of a sense, I think, that pain isn't always scary, that pain doesn't always mean you're screwed, and that this other stuff in your general health can be important. So there's swinging around and roundabouts in that. The way I'd look at it sometimes is that you almost want the experienced clinician to triage people very well. And then sometimes it's actually nice to have the young, optimistic, almost naive, but positive physio to coach them through the lifestyle stuff, and because they won't sweat about the consequences of things. So that's too much of a simplification, but you know what I mean.
Yeah, and I think it's also nice to recognize that you have always got really great people that you can speak to. So if you are worried or if you are unsure, speak with your colleagues or connect with someone who's outside your network. There's a ton of people out there and we all want to support each other. So I think it's internalizing this sense of, oh, I'm such an idiot, I should be able to do this. And that's not helpful to anyone. So I think feeling like we are connected and we are a community, and that's why we do these live chats, is to try to support each other through some of these more challenging situations.
It is, and it's not always possible because there's a whole series of political and professional boundary reasons that we don't work with other professions. But some of the best people and the people I've learned most from haven't been physios, for example. And I have learned great things from people outside of physio, and I've also seen some truly shocking practice in other professions outside physio that made me realize physio is actually pretty good at some of this stuff. That we might think, well, he's an orthopedic surgeon, so he must be good. And actually, sometimes we underplay how good we are at some of the stuff we do. So I think there's probably value in that. Just to follow up on that, I knew that another thought that came to mind. One of the things I'm doing at the moment, one of the best ways I've learned, but also the toughest, is video recording yourself or seeing other patients with physios in the room. And it's a brilliant experience, but it's really important that it's in a safe, trusted environment. So if you go back to, when we're all students and you're doing presentations or seeing patients on clinical placement, it can be a very tough, stressful process, and it doesn't have to replicate some of the worst experiences of your life. So I wouldn't tell people to do it if they were nervous or if they felt it wasn't a safe environment. But if at all possible, seeing people with patients with people from a different perspective is actually very useful. And at the moment, as part of a couple of trials I'm doing some fidelity video assessments of physios in other countries, and it's amazing. And in one sense, I'm the person that's supposed to be seeing if they're doing things right, and I'm watching these saying, I'm going to try that the next day because this looks really nice and interesting. So it's daunting to be the person being watched, but it can be in the right hands, because I really think it can go horribly wrong, but in the right hands, it can be very positive and nurturing. And I've been really lucky to have people like Peter Sullivan knows to mentor me down the years and all the rest of it.
I want to move us now to load management, because I think we've dealt lots with perhaps the psychological and a little bit the social aspect of our biopsychosocial model. And I do want to bring us back to the biological part of it. And I would love to hear your thoughts on load management, Kieran, and really what are your guiding principles for load management in people with people with back pain?
So important caveat, I really don't know that much about the principles of load management. And so again, if we were really talking about load management of elite athletes, I'd be handing this over to the sports scientists and maybe some of the physios who know an awful lot more about it. I do think there's an important lesson in the general principle of load management for back pain, because if we look at what we've learned about back pain, the management historically and even quite recently has been still around the idea of, well, you've hurt your back, avoid putting pressure on your back. And even the positive has been around, well, we'll strengthen other parts of your body and we'll cross-train it, but your back, we got to rest it. Or when we're doing any training for it, it can tend to be very subtle, very, very gentle, easy stuff. So going back to the manual handling idea, don't, if you're going to be a manual worker and your job is going to involve lifting 30 or 50 kilos repeatedly, the load management principles would tell us, well, you better practice that. The ergonomic manual handling principles would tell us we should probably not do it because we'll wear out the back. So the load management principles are important because in management of spinal pain, we haven't always done it. So that's important in one sense. But I think another real challenge has been in the event that somebody develops pain, how much do we keep them going so that they don't lose all their fitness and all the confidence that they need to return to sport? One of the examples I give sometimes is, when you and I were both in Aspetar and Qatar for a while, for example, and over there you'd see a lot of adolescent boys, 16, 17, 18 years of age. And it's really common they will get a sore back when they start increasing their training load. And quite often that will be associated with a stress response in their PARs, so they'll get some bone marrow edema and sometimes even a change in the continuity of the bone, maybe a stress fracture. Now, those kind of conditions, the onset is associated with an increase in load, and the management is a decrease in load in the short term. What we're really not sure about is how much do we reduce it and for how long. So if you want to be really conservative, you can say, yeah, take a year off and lie in a bed for a year, and the edema will almost certainly reduce. But nobody can say with any confidence that we know how much we should back off. And do we back off all load or some types of load? And so my sense, I'm probably considered as being a bit more aggressive in those management of those conditions than other people. So my principle, if we look at the PARS example, for example, we know that when we follow people up over time, and this is counterintuitive to me, the likelihood of you developing back pain is not different according to whether the bone heals fully or not. And again, that's counterintuitive. All my instinct would have been, well, no, if the bone heals, you'll do better. But it turns out it's a lot like the rotator cuff tears and shoulder pain, that the people with the worst tears don't necessarily get more pain. So my criticism of some of the management of those type of conditions would be, like myself in the past, person would have had pain when they're exercising at this level, so our response is drop it 100% for a long time. And whereas now I would say, well, if it's like no sign of serious things that we're worried about, like cauda equina, spinal cord injury, anything dangerous, what's wrong with dropping it a smaller amount, 20%, 30%, pick a number, and assessing the tolerance for a week or two. Because if you drop it right down 90, 100%, you're going to be a hell of a long time building that back up. So that has, I would say, two benefits. Number one, it improves the likelihood that they can maintain physiological fitness. But number two, it breaks the link between I get back pain and therefore I have to stop all training. And that's an important thing. If you think about the development of, in this case, male athletes, but adolescent athletes, male or female, it's a time when they're going to get exposed to high loads and they're going to get some niggles. And we're not in any way encouraging them to hide those niggles, but they've got to understand that listening to my body and having an appreciation of how much I can push my body, that it doesn't have to be 0%, but if I'm getting problems at 100%, I might have to back it off, listen to my body, check on my recovery, sleep, recovery, training, monotony, but then nudge it back up and use that sense of trusting their own body. Because my sense a lot of the time is we've absolved the athlete from having any ownership of that. That we're telling them, well, you've hurt your back, so your return to sport will be dictated by an MRI scan and a GPS unit. Instead of saying, your response, you've got some pain, we're going to back you off, we're not sadists, we're going to kind of give you a chance to feel a bit better. And then we'll dip our toe in the water, but we're not dropping you way down. The only other thing I would add about that is that there's a lot of controversy in the social media world now about how we measure load and all the rest of it. And I know particularly people like Tim Gabbett, I would say, have done a lot of work in kind of popularizing the understanding among physios of chronic load management. Now, I don't know if in 10 years' time, how will this be saying you should monitor training load, whether that will be still GPS units or, exponentially weighted averages and all this kind of stuff. But I would say to some people would say, look, we know this stuff for years. Good coaches always knew you kind of push people along gradually and give them a chance to recover. And I would say maybe they always did that. I did physio, I did a master's in physio. It really wasn't a big feature of my understanding of any of these aches and pains. And maybe I'm an outlier, but I don't think we've really focused in on that. So if I went back to my notes in some very good universities 10, 20, years ago, the focus was still on a lot of other things and not the understanding of training load. So I think those like Tim Gabbett, who have popularized it amongst physios and sports medicine physicians, deserve a lot of credit for that, while acknowledging it doesn't predict everything, and the exact formulas that we are using to calculate these things are almost certainly going to evolve over time.
Now, you used the athlete example, but what really resonated for me was these principles of managing load, not dropping, not boom bust sort of it's all or nothing. Drop down a bit, test your capacity, know what it is that you're getting back to. So that aspect of goal setting, all of the good recovery stuff. And to me, that's resonating with a lot of the principles that I learned about pain education. And so this sense of, knowing what your body is what your body can tolerate, and then gradually slowly building that up, and that some pain is okay, and getting a feel of sort of what your body can tolerate.
And I think there is something to that. Fiona Wilson, who I know in Trinity, is she's doing a lot of stuff at the moment on rowers and back pain. And one of the people she was looking at was the experience of back pain in rowers as they got older. And there was a sense that, loads of rowers will get back pain, but it's almost not considered, it's kind of like not quite a badge of honor, but it's just an occupational hazard to a certain extent in some of those sports. But there was a sense that as you got into being the more experienced rower, you knew this is the kind of stuff I get when I up my training load, so I'm not worried about it. As opposed to, that's a bit different. And that's one of the challenges with an athlete with who's only been training intensively for 6 months or 2 years. They don't necessarily know their body and know this feels right. Yeah, I've been here before, I can push on. I'm just, overstretching myself a little bit, as opposed to, God, this is different. And so a big part of that is that communication of trying to understand and learn from what does it feel like, and even if it isn't what it feels like now or while you're doing these exercises, what's like the next morning. And over time, athletes will often develop a sense of what they know works for them. But again, I suppose the message I would have given myself, I wish I had got a few years ago, was that we'd like it to be pain-free. We'd like you to have no pain. But if we set the bar as it must be entirely pain-free before you do exercise or before you return to sport, we'll be keeping you out for a hell of a long time. And again, so I'm still, even if I see a patient next week and they've got some pain, I'll try and find ways to help them move with less pain, because it's nice for them and it might even help compliance a little bit. But all the evidence would tell us that it doesn't have to be pain-free, irrespective of spine or otherwise.
Now, lots of people are working from home at the moment, and people watching this recording might be getting questions from their family or from friends who perhaps don't have a musculoskeletal or rehabilitation background. And they might be questions about ergonomics, or they might be questions about desk setup, about posture, about sitting upright, and about having the screen at the right height. What advice would you like to share about posture and its relationship to pain?
Cool. So I'm going to answer this in two parts. I'm going to say, if we leave out the part of you're working from home right now, I'm going to say that if you are somebody who is pain-free and is sitting at a desk normally, then just keep doing what you're doing. Don't sweat changing anything. Because based on what we were just talking about, load management, if you've been sitting at the desk and you've been pain-free for the last 6 months, you've adapted, and you probably, it's working for you, so why would you change it? Same as you've worn those shoes or that brand of runners, go with it. And so generally, I would say we've oversold, and we've written a piece in JOSPT around how we've oversold the importance of posture and ergonomics, and particularly how we've pushed a certain kind of aesthetic model of posture, especially, unfortunately, if you're a woman, heaven forbid you would ever not carry yourself with a certain type of deportment and hold your body a certain way. There's a whole series of societal reasons why there are expectations around what we should look like, and posture is one of them. I'd put a small proviso on, or a kind of caveat on it, in the current environment. Now, I would say there's probably quite a few people who are now working at home and are now getting a bit of neck and back pain that they didn't normally. Okay? And I would say, actually, even though I think posture ergonomics are massively overrated, it could be part of what's going on at the moment. Partly because their workstation mightn't be very well set up in typical terms, but I'd say actually just because a lot of time it's just a very big change in load. So if I could say there's two big things I'd look at the moment, I wouldn't necessarily be too worried about making sure everybody who ever works at home has an ergonomic workstation, if I use that term. But if you've just gone from a certain type of way, desk, chair that you always sit on, to another one, that's a change. Okay, so that in itself is one part of it. So for example, even as I'm here at the moment, I have a desk and a chair. It's pretty comfortable. It's still different to the one I usually sit on at home. It doesn't mean it's worse. It just means it's different. It's a bit like changing shoes. Not worse, but it's a difference, and that does change the loads. So I think that's part of it. And so I would say it's worthwhile for people who are now changing their office environment. If you're going to be working on a laptop or whatever else, try and find a way that makes you comfortable or is like what you'd normally sit on. The second thing I think that we need to talk about, though, is that it's not the only thing that's changed. So I work at home typically 2 days a week anyway. And on those 2 days of the week, the kids are never in the house. And my wife is also not in the house. And I'm not trying to kind of juggle a whole lot of other things that's going on in between. So critically for me, as much as we're having that discussion about the ergonomic stuff that's changed at the moment, all the evidence tells us work-life balance, stresses, strains, on things that are uncertain. And there's a whole lot of that going on in the world at the moment. So when I spoke to a friend of mine the last day who was saying she's working at home and her neck is very sore since she got there, I would say, like a lot of people, her office desk ergonomics are different, and she could probably benefit from spending some time at making that feel comfortable, not necessarily straight, but comfortable. But when we spoke about what was going on, she has concerns about her parents' health at the moment. She has concerns financially, and there's just a whole lot of chaos going on in her life due to COVID-19 and all that kind of stuff. And so, same as anybody, there's probably a mix of the bio and the psycho and the social going on in that. So, if you can find a comfortable way to sit at home, great. I would suggest that the comfortable way to work at home probably looks a lot like the comfortable way you normally work, whatever that was.
And the other thing I think quite a few people will have been doing is getting home gyms set up and doing different exercise programs than they may have been doing in the past. Have you got some advice to share about lifting and particularly around strength training?
Essentially, no. So that's not very useful. What I mean by that is I think all exercise is generally good, and generally say if I sometimes challenge students in class to say, name one exercise that is dangerous uniformly that nobody should do. Because, people will say, well, running doesn't suit me and swimming doesn't suit me and so on. Or weightlifting, I did it once and it hurt my back. I think the issue there, and you touched on it, is not the exercise they do, it's the unaccustomed, frantic nature of it. And so there'll be a lot of people where, I'm fortunate enough to work in a university with a 50-meter pool that's been closed now for the last 2 months. There's a lot of people where that is their form of exercise and that's gone. And some of these people do large amounts of time in the pool and they're going to be searching frantically for something that gives them that same sense. And there's a chance that they do another form of exercise, which is not dangerous, but if they try and do it at the intensity and volume that they have been doing it, they might kind of get into a spot of bother. So I would suggest it's very boring. I would suggest all exercise is good. If you haven't done it before, start gently and see how you go.
Good advice. Thank you.
You wouldn't spend a lot of money on that kind of advice, let's face it though.
That doesn't mean it's not good advice.
Yeah.
As we get close to the top of the hour, I want to wrap up by talking a little bit about telehealth. This is a question that we've been asking quite a few of the guests that we've had on recently because it's become a common way of working for lots of our community. And I'm interested to hear your thoughts on telehealth and how the aspects of telehealth that could work really well with people who have back pain and helping support them in that return to activity plan, and some of the things that might be barriers and perhaps how we might overcome some of those barriers.
Cool. So it's interesting in ways, we can't say there's anything particularly good about COVID-19, but it has been interesting to observe that all the things that we're often told are impossible that are suddenly possible. It's impossible that you wouldn't have, a 3-hour staff meeting every week. Suddenly it seems to be somewhat possible. But even in terms of, before I come to your question, if you're a physiotherapist registered in one part of the country that, you couldn't possibly be registered quickly in another part of the country, it would have to be a big, long, cumbersome process. And, when the pressure's on, we can find ways to be flexible and so on. I think in the awfulness of the current situation, it has shown that it is possible to provide care at a distance, and there's been people like Kim Bennell doing trials on this for a while. So it's possible to provide good care. And if you look at the really important stuff that's described in most of the guidelines for back pain, hip pain, knee pain, it's the kind of stuff you can do with some caveats via tele-rehab. So I think it's possible. There's been a couple of big barriers, and unfortunately, I don't think they're going away. So the barriers, I would say, are in places like Ireland and lots of countries having good broadband signal and so on to make sure people can access it comfortably, but also issues around funding. So for example, there's been a challenge in some countries getting physios or kind of rehab broadly delivered by rehab to be fundable. And so, for example, you can't be surprised that physios will make people come into a clinic if they're going to be able to charge for that and not delivered by tele-rehab online. And then the other challenge, I suppose, is, which hasn't been as much of an issue in some ways, getting patients to see value in tele-rehab. I know I have anecdotal reports, and that's all it is, of some physio practices finding it much easier to transition to tele-rehab as opposed to other practices. And, those anecdotal stories would support the idea that if you're very dependent on passive treatments that you do to the patient, they won't see the value in the tele-rehab. Whereas if the patients understand that what I'm getting from these sessions with Clare is a lot of explaining what's going on, figuring out why I was sore last Tuesday, and figuring out how I settle down this episode and get back on the horse and build myself up, then you can do that pretty well in a tele-rehab setting. So thankfully, this too shall pass. And I think it's perfectly fine that people will go back to a lot of in-clinic rehab. It's just that I think the tele-rehab should be a viable option. I do a little bit of it, not an awful lot. And there are some simple things that I found that are probably troublesome. So for example, it's almost always the first thing is the broadband. Secondly, it's the video conference on a tablet or a laptop as opposed to the phone, just in terms of if you want to be able to observe the person and see what they're doing and almost kind of guide them through the movements you're talking about. You want them to be able to lay it down and have a good view and all that kind of stuff. And then there's other basic things that are useful, but also you need to be careful of in terms of, so can they record the session? Are you recording the session, and understanding what the use of that is for? And again, we'll get more on top of those things over time. But I do think it's an opportunity. It isn't, I think there's a sense at the moment that, it'll change the world. It won't change the world, because if people will still resort to going back to clinics. I think people will always understandably want some of that personal connection and the face-to-face element. But I think it does tell us where the value is in what we're offering. And if patients haven't all just stopped attending physio because of the lack of physical contact, it means there is at least an openness to that.
Absolutely. And I will take the opportunity to plug Kim Bennell is going to be a guest in an upcoming live stream. So we'll have a great opportunity to learn from her extensive experience, as you mentioned, running trials, illustrating the real where telehealth can be really beneficial. And there's been other trials within pulmonary rehabilitation, some great work out of Norway and Australia. And I'm aware of some other trials looking at tele-rehabilitation delivered via telephone. So where it can be a challenge, and I'm really glad you raised the point about broadband. And I know even my parents who live in country Victoria in Australia, they are not that far from they're half an hour from a major regional centre, and there is no broadband, and there will never be. So these sorts of access issues can be a challenge even for people for whom we might expect are really literate in these sorts of platforms, and they just can't access it for different reasons.
Just on the issue you mentioned with Kim Bennell, if people are wondering what kind of resources they can use, Kim Bennell and her group have some really great tele-rehab resources that people can use for knee osteoarthritis that they've disseminated on social media recently.
Yeah, and we can link to some of those as well. I haven't got them on the top of my head either, but you've brought us beautifully to almost to the finishing line, and I was going to ask you for your recommendations on some resources that people might find helpful, particularly resources that they might direct patients or family members to, and also resources where they can learn more.
So traditionally, a lot of physios and physio students would have asked, what books do I buy? And there are some great books out there, of course, but increasingly, especially when you can get so much free online, it's harder to justify spending an awful lot of money on some of the books. I would suggest it depends what people are looking for. So a lot of the time when I'm sending people to resources, it's not physios, it's patients. So I'm sending patients to have a look at this. And a lot of the time I'm not telling them to look at some of the really great people like Lorimer Mosley and David Butler, Peter Sullivan, but look at the Pete Moore has that website, Pain. He's the Pain Toolkit, and he's on social media. He's a fabulous guy, and he's, as a patient who has recovered and managed very well with his persistent back pain, has some great resources that patients can relate to. And we have a website, pain-aid, so painaid.com, that there has a patient story section, and it's patients talking about their own story. I send patients to those kind of places for two reasons. First of all, almost to reinforce that I'm not a complete nutcase, the only person in the world that talks about this kind of stuff. And secondly, that they might find somebody that's more relatable. So it might, because it's like, well, they're the right age, the right pastimes, the right hobbies, and so on. But then beyond that, if I was going to talk about the resources, I would ask physios to check out, look, anything by Lorimer and the Body and Mind crew. I would say our own website, Pain Aid, is pretty useful. There's a Helen Slater and her group have Pain Health in Australia, painhealth.edu, I think it is. And there's a whole, like, NOI is always a good resource to check out. And then obviously, it's kind of just the way the world has changed, but any of the vast range of podcasts that are out there are all worth checking out, with the proviso, or with the kind of caveat that I probably listen to less of them on my runs, my slow runs now than I used to, because while they're very useful, sometimes it's nice just to listen to the wind and the rain in Ireland.